Before the operation begins, the spacer is soaked in a sterile saline solution at room temperature. The CMC1 joint is exposed by making a dorsal incision. The size of the incision will vary from case to case. The dorsal branches of the radial nerve, the dorsal branch of the radial artery, and tendons are retracted and fixed with sutures. The periosteum flap from the trapezial bone, including the articular capsule, is raised and moved distally. The opening is enlarged by lifting the articular capsule attachment and the proximal dorsal periosteum away from the first metacarpal, moving them dorsally and fastening them with sutures. Using the spacer, the placement of the horizontal wings is marked. The joint surface and 1 to 2 millimeters of the distal trapezial bone are chiseled away with an osteotome to create a bleeding surface. The proximal surface of the metacarpal is left intact, with the exception of any osteophytes, which are removed in order to create a new joint surface. The dorsal cortical surfaces of the trapezial bone and the first metacarpal are removed, using an osteotome to make room for the wings of the spacer and to create a bleeding surface. The spacer is now fixed in place using sutures or screws. The spacer, which has been soaking for at least 5 minutes, is now positioned. The wings of the spacer are fitted onto each side of the trabecular bone. If necessary, the ends of the wings can be cut to size, but the sides must not be cut. Drill through the center of the wing of the spacer at the metacarpal bone until the bit penetrates through volar cortical bone. Be careful to hold the drill straight so that the tip of the screw will not be pointing towards the joint. Measure the length of the screw carefully. This is done most easily if the gauge is not passed through the spacer. Tighten the screw until you feel that the screw is firmly seated in the cortical bone. Fix the thumb dorsally and drill, measure, and tighten the screw also in the trapezial bone. It is important to reposition any subluxation of the joint. Another method is to fix the spacer with sutures. The holes drilled for the sutures are placed at the corners, preferably 4 to a wing. The spacer is fixed in place using multiple single non-resorbable sutures threaded through holes drilled in the bone. The sutures nearest to the joint are tied first. After the spacer has been fixed in place, the periosteum flap is sutured back on and the incision in the skin is closed. The thumb is immobilized at 30 degrees volar and radial abduction using a plaster bandage which must be changed after 2 to 3 weeks. At this time, the IP joint of the thumb will not be covered by the cast. The total bandage time must be at least 5 weeks. Place a roll of wadding to keep the thumb in 10-degree flexion before the plaster is applied. It is important to keep the load exerted on the spacer to a minimum and to see to it that the MCP joint is not in hypertension. This should be done to avoid problems with the annular ligament.